Good afternoon, everyone. My name is Rohan Kurian Thomas. I'm here to present a talk on thermal ablation techniques. Before I begin the presentation, I would like to express my heartfelt thanks and appreciation to the Dean and Director, Allied Health Sciences, Vinayaka Mission Research Foundation, Dr. Sendil Kumar, to Mr. A. Selvakumar, to Commander K.J. Daniel, to Mr. T. Suresha, to Mrs. V. Kalevani, to Ms. Ragita, to Mr. Imbasagar, to Ms. Preeti, and all the members of the organizing committee for giving me this wonderful opportunity. Now let us begin with the introduction. The term ablation refers to the destruction of a tissue by heating it to cytotoxic temperatures. Ablation involves the use of chemicals or thermal energy delivered directly to the tumor to achieve necrosis. Temperatures in excess of 60 degrees Celsius are known to cause relatively instantaneous cell death, while temperatures from 50 to 60 degrees Celsius will induce coagulation and cell death in a matter of minutes, depending upon the temperature and previous thermal injuries. Now let us have a look at the types of ablations. There are two main types of ablations. One is hyperthermic ablation and the other one is hypothermic ablation. Hypothermic ablation refers to the medical treatment in which body tissue is exposed to higher temperatures in an effort to treat cancer, whereas hypothermic ablation is just the opposite of that, where it is exposed to extreme low temperatures in an effort to treat cancer. Under hypothermic ablation, we have radiofrequency ablation, microwave ablation, laser, HIFU, and under hypothermic ablation, we have cryoablation. I would like to give you a small preview on how normal cells behave to heat. 40 degrees Celsius, cells are more susceptible to heat and cellular homeostasis is maintained. What is homeostasis? It's the tendency of the cell to resist changes in order to maintain stable environment. So from 42 to 45 degrees Celsius, hypothermia takes place. Now hypothermia is where the heat regulating mechanism fails in the cell, and therefore it results in the abnormal increase in body temperature. At 45 degrees Celsius is irreversible cell damage in few hours. Between 50 to 55 degrees Celsius, you have irreversible damage in few minutes, maybe 4 to 6 minutes. And from 60 to 100 degrees Celsius, you have instantaneous cell death by protein coagulation. And above 100 degrees Celsius or more, we have tissue boiling, vaporization, and carbonization. Sources of these thermal heat. So where does all this heat come from? For various ablations, it's different forms of heat. For radiofrequency ablation, it is electrical energy. For microwave ablation, it's electromagnetic energy. For light ablation, it's laser. And for ultrasound ablation, as I said, HIFU, high intensity focused sonography, basically sound waves. Let us see now about the applications for various ablations. So the applications are as follows: inoperable primary, metastatic and recurrent tumors, patients not suitable for surgery due to comorbids, palliative care for advanced cancer patients, patients unwilling for surgery. Now let us take a look at patient preparation. 12-hour fasting is required. So why 12-hour fasting is required is, in some institutions, they do the procedure under general anesthesia. So if the procedure is done under general anesthesia, 12-hour fasting is required. If it is not done under general anesthesia, 12-hour fasting is not required. Then physical examination is a must. Written consent, the patient should be informed of what kind of procedure has been done to him, and also the complications that thereafter might add on. Coagulation profile, PT, PTT, INR, and RFT values also are taken. Now, these various approaches to various ablation techniques. So the main three approaches: percutaneous, laparoscopic, and open surgical access. Percutaneous means through the skin. Laparoscopic is a fine incision, a small incision. And as it suggests, open surgical is a larger incision and by opening. Now, before I go into the gist of everything, let me just do a simple concept. What is current? Flow of electrons during a period of time. And how is it measured? In what is it measured? It's measured in amperes. Circuit. What is a circuit? A pathway for uninterrupted flow of electrons. Now we come to radiofrequency ablation. RF energy is an alternating current with a range of frequency between 10 to 900 MHz. RF waves have low wavelength and as such are of very low energy. Like for instance, if you can see here, so this is the RF generator from where an electrode is connected to the target tissue, and from there grounding pads are placed on either side. So this is the completion of the circuit. So now I will talk about grounding pads. Now, as I said, the completion of the circuit. So from the RF generator, it is connected to the electrode, and from there also is connected to the grounding pads. So this completes the circuit, thereby minimizing the risk of burns or electrocution to the patient. So what these grounding pads are also called as dispersive pads. So when, as it suggests here, for RFA of lesions of lung, liver and kidneys, the grounding pads are placed on the thigh, and for the lower limbs like osteo or osteoma, the grounding pads are placed behind. So why is it called as dispersive pads? Now, it's not only useful for the completion of the circuit, thereby minimizing the risk of burns as well as for electrocution, but also the heat that is generated at the electrode has to be dispersed properly out of the body. These dispersive pads help in dispersing that heat. So what is the principle of RFA? In RFA, an electrical current in the radiofrequency range is delivered through a needle electrode under image guidance, surgical guidance, producing heat-based thermal cytotoxicity. So RF energy flows through the electrode, which causes ionic agitation, then comes friction, which causes the heat generation, and therefore the tissue gets desiccated by that heat. So how does that work? If you see the picture on the side, alternating current comes through the electrodes and it starts to alternate. As this alternating current is passed through, the ions in that region start to fix themselves. They try to fix themselves to the alternating current. As they fix themselves to the alternating current, they start to vibrate rapidly. And as they vibrate rapidly, they cross friction. And this friction is what causes the heat to get generated, which causes the tissue to get desiccated and necrosed. I repeat again. As you have the electrode, the alternating current is passed through the electrode to the target lesion. And in the target lesion, the ions, the dipolar ions, they try to fix themselves to the alternating current. As they try to fix themselves to the alternating current, they start to vibrate rapidly. And as they vibrate rapidly, they cause friction. And this friction then generates heat. As the heat is generated, this heat is used to cause tissue desiccation and necrosis. Now let us see the different types of electrodes which are used in RFA. First off is the monopolar type of electrode. A single interstitial electrode is used to deliver current to the tumor site while surface pads complete the electrical circuit. As you can see here, the RFA device, a single electrode, and it is connected to the grounding pads to complete the circuit. Next is the bipolar type of electrodes. Current flows through two electrodes at the tip of a single applicator. Let us have a look at this picture over here. So this is a single applicator which has two, that is number 1 and number 2, two electrodes, and with an insulator in between. There is no need for grounding pads, neutral electrodes. Like you can see in this picture, there are no grounding pads. Electric current enters and electric current flows out through the other electrode. It also requires internal liquid circulation, which keeps surface temperature moderate and prevents the tissue from charring and vaporization. Then comes the multipolar type of electrode, where current flows through all possible combinations. Even 2 to 3 applicators are used. As you can see, there are multiple prongs. These are multiple electrodes, multipolar electrodes. Okay. So what is the advantage is that it has larger area of coverage. It is effective treatment. There's no need for the grounding pads and neutral pads. Electrical current is localized to the area of the treatment. Now let us look at an RFA procedure for a patient with osteoid-osteoma. The dispersive pads are placed behind the patient's back. CT slices are acquired and planning is done. At the level of the entry site, a marker is placed. Under aseptic conditions, there's a small incision being made, and through that, a needle is placed inside. So this needle is called the Murphy's needle, that is a bone biopsy needle. And using the Trufine method, that is clockwise, anti-clockwise rotation, the needle is inserted into the incision point. Then using a drill and a K-wire, the target is acquired, the target lesion is acquired. Then the placement of the electrode. Then using an RF generator, the RF alternating current is being applied. If you can have a look here, this 90 is the target temperature, this 150 is the power of the watts, power in watts, 45 and 88 here are the thermocoupler temperatures. So these thermocouplers are basically at the tip of these electrodes. You have a thermocoupler, and that feeds in the information of how the temperature is at the tip of the electrode. Then after the procedure is done, check CTs are done to see how well the ablation has taken place. Now let's see about saline enhanced RFA. Like I said before, this is the RF generator. You have, this is the target temperature, the power in watts, your thermocoupler temperature, and also your electrodes and your grounding pads. On the side is your saline infusion setup, where you have the saline source, the saline infusion pump, and along with the prongs, the saline infusion takes place. Now, so I need to explain to you what exactly happens. Now, take for instance, without saline, what happens? In RFA, without saline, at the tip of the electrode, as your alternating current comes in, as the heat is generated, microbubbles take place. And so these microbubbles, they move to the other areas of the tissue. Rather than at the center where the electrode is, at the tip of the electrode, where the target lesion is, these microbubbles start to move on either side, move to the peripheries. So as these microbubbles move to the periphery, what happens is the moisture at the center where we require the region to be ablated, the moisture at that center diminishes, it decreases. So as I said before, when RF alternating current is passed, it is the water molecules, that is the dipole water molecules, that start to vibrate rapidly. So if there is less moisture, there's less water molecules. If there's less water molecules, then there's less electrical conductivity and there's less heat generated. And so the ablation is less. So with a constant saline infusion, what you maintain is moisture at the tip of the electrode. These microbubbles will form, they will move to the peripheries. But with the saline infusion, what we guarantee is that there is a constant supply of moisture at the tip of the electrode. So there is increased electrical conductivity, hence there is a constant generation of heat and a good ablation takes place. So this is how the procedural outcome takes place. So as you can see, the center, where there it is here, is the necrotic region, and the white region above this is called the coagulation zone, and the red region here is called the congestion zone, where there is partial necrosis taking place. So complete necrosis in the center and partial necrosis is the side. Now let us have a look at microwave ablation. Microwave ablation is also a form of thermal ablation used in interventional radiology. Microwave ablation uses electromagnetic waves in the microwave energy spectrum which ranges between 300 MHz to 300 GHz to produce tissue eating effects. So what are the advantages of microwave ablation over RFA. Larger zone of active heating in short time period, better performance near blood vessels, so there's less of heat sink, which I will speak about later, and higher temperatures attained. And the area of, so like as I said, the larger zone, so the zone is more in that area, so the ablation is better and the target tissue is encompassed in that ablated zone. So let us talk about the principle of microwave ablation. What is the principle of microwave ablation? Very simple. Electromagnetic radiations in the range of 300 megahertz to 300 gigahertz is applied, which agitates the water molecules, which causes frictional heating due to dielectric heating, which causes cell death, coagulated necrosis. So let me talk in detail about dielectric heating. Now, what happens here? An alternating magnetic field, when applied through the microwave generator, through the microwave antenna, an alternating magnetic field is applied. When an alternating magnetic field is applied, the water molecules, they try to align them, that is the dipolar water molecules, they try to align themselves to the alternating magnetic field. Okay, this effect is called dielectric heating. This effect is called dielectric heating. So what happens is, dielectric heating occurs when an alternating magnetic field is applied to an imperfect dielectric material. Here we have the imperfect dielectric material is the target tissue, and inside the target tissue, where I am concentrating on, is the water molecules. The dipolar water molecules, as the alternating magnetic field is applied, they oscillate in and out of phase to the alternating magnetic field. This oscillation takes place rapidly, billions of oscillations per second, which causes kinetic energy, which causes heat to be generated, which causes that heat to cause cell death and necrosis. As you can see here, the propagation of the wave, the blue signifies the magnetic field and the red signifies the electrical field. So electromagnetic wave propagation, here same thing in a 3D format, where you see the red signifies the electrical field and the blue signifies the magnetic field. Then in contrast to electrical currents, microwaves radiate through all biological tissues, including those with high impedance to electrical current, such as lung and charred or desiccated tissues. Now let's have a look at other various ablation systems. So the ablation system comprises of microwave generator, microwave antenna. Now these are the microwave antennas, and this is the microwave generator. Now, what attributes to a good microwave antenna? So what are the good qualities for a good microwave antenna? So the shaft is high strength, so titanium alloy, so it's high in strength. Different shapes of handle, L or straight, can be manipulated. Multi-length available for the shaft, meet different puncture depths. Real-time temperature monitoring ensures the safety. Advanced anti-adhesion technique prevents adhesion effectively. And also enhanced, so makes puncture, so it's enhanced sharp end, makes a good puncture. Okay, now let us have a look at how the procedure for a microwave ablation is taken place. Under CT guidance, the target lesion is acquired and the approach to the target lesion is made. So a marker is placed and the needle is placed at the marker. So we have the target lesion acquired. It can also be done under ultrasound guidance also, where you can see over here the target lesion is acquired and also the approach to the target lesion is marked. Then the placement of the antenna at the target using the microwave generator, heat is applied, 66 watts during 6 minutes is applied so that a proper ablation takes place. So these are the various ablation zones for microwave ablation. This varies with watts, so at 20 watts, 40 watts, 60 watts, 80 watts, 100 watts, as you can see. And it is also time based, so it varies with time. So at 20 watts for 3 minutes, this is the ablation zone. For 40 watts, 10 minutes, that's the ablation zone. So this is the different types of ablation zones. So Like this is the post-procedural outcome. So like I said before, the center is your charring zone where there is complete necrosis. On the white region is the coagulation zone, and there the red is the congestion zone where you have the partial necrosis. What is heat sink effect? This is a phenomenon that occurs when the thermal energy which is applied through the RF applicator gets dispersed from the target lesion due to the blood flow in the vessel adjacent to the target lesion. So if there is a vessel that is nearby to the target lesion, as the heat is applied, the heat disperses from that target into the blood vessel. As the blood flows, it takes the heat along with it. So this heat sink effect diminishes the effect of the ablation, which is not a factor. It is attenuated in microwave ablation. So you can see here the comparison between RFA and microwave ablation. In RFA, you can see there's a clear deviation, so there's a heat sink, that is, the heat gets deviated. Whereas in microwave ablation, in the ablated zone, there is no, the heat sink effect is attenuated. Now, what is charring? Charring is a chemical process that results in the burning of tissue when subjected to high heat. Charring is basically it's a chemical process of incomplete combustion of certain solids when subjected to high heat. The resulting residual matter is called char. So what happens here? By the action of heat, charring removes hydrogen and oxygen from the solid tissue. So what remains is only primarily carbon, that is char. So this is what happens when charring takes place. Okay, I would like to give you a small comparison now between RFA versus microwave when it comes to the heat sink effect. Now, let's take, for instance, these two pictures on either side. One is the radio frequency ablation, and the other is a microwave ablation. So like, for instance, you have the RF power supply, you have the electrode, and you have the tumor, which is in red, to be ablated. You have yellow, the ablation zone, and the white is the blood vessel, which causes the heat sink. Like I said, heat sink effect is when there's next to the target lesion, if there's a blood vessel, the heat sinks into that blood vessel and moves along with the blood flow. So the ablated zone is less, there's less heat in the ablated zone. So the ablation zone is not effective enough to encompass the entire tumor. So that is what happens in RFA. But when you have a look at microwave, you same thing, power supply, microwave power supply, and you have the antenna. There are also, so this is the red, the tumor to be ablated. The yellow marks the zone, ablation zone, and there are also blood vessels close to the tumor. But the difference between microwave and RFA, and I want to stress on this point, is that the heat sink effect is attenuated in microwave, whereas in RFA it is more present, the heat sink effect. So since the heat sink effect is attenuated in microwave, the heat does not dissipate or disperse along the blood flow. So there is more heat present at the zone. So there's a larger ablation zone, and that encompasses the entire tumor, and so more effective tumor ablation. So this is a basic difference between RFA and microwave when it comes to heat sink effect. Another comparison I would like to make between RFA and microwave ablation is when it comes to difference in temperature and time. So x-axis here, let's take for instance this graph with the x-axis being as time and y-axis temperature in degrees Celsius. So at a constant 100 degrees Celsius, with the variation in time, you can see that the RFA, which is signified by the red, and so the RFA, which is signified by the red, and the microwave ablation, which is signified by the blue. Now, RFA remains almost constant heat generation throughout time, but when it comes to microwave ablation, as time prolongs at 100 degrees Celsius, there's a gradual, you can see there's a gradual increase in the temperature along with time. So what this means is there is greater heating effect and larger ablation zones when it comes to microwave ablation. So it's more effective. Whereas here the heating effect is there, but it is not increasing, so the ablation zones are not as effective as microwave ablation. So now let us have a comparison between radiofrequency ablation and microwave ablation. Radiofrequency ablation relies on tissue properties such as electrical conductivity and thermal conductivity. Microwave ablation relies on tissue properties such as relative permittivity and effective conductivity. So what is electrical conductivity? So I need to make a note on electrical conductivity. So electrical conductivity is inversely proportional to the impedance in the tissue. So greater the electrical conductivity, lower the impedance in the tissue. Lower the electrical conductivity, higher the impedance level in the tissue. So then now comes thermal conductivity. What is thermal conductivity? So basically it is just thermal diffusion. Okay, it is the ability for heat to pass through a material. That is thermal conductivity. So in the instance for RF ablation, thermal conductivity means heat from that region where that electrode, where heat is being generated, from that region, how fast the heat moves from that region to the surrounding tissue is thermal conductivity. Whereas in microwave ablation, the tissue properties are a little different. It's relative permittivity and effective conductivity. Now, relative permittivity is basically like the word says, permittivity. It's basically that the material, that is the tissue or the material, it's the ability of the tissue or the material to accept the electrical field when compared to the relative permittivity of vacuum. I'll repeat again. Relative permittivity, as it says in the name, is the acceptance of the electrical field by a material or tissue when it is compared to the relative permittivity of vacuum. And when it comes to effective conductivity, now let's say for instance we're having a tissue from the liver and we have a bone tissue. Now the liver has more water molecules than the bone tissue. So the liver will be more effective conductivity for microwave ablation because there are water molecules. It will oscillate. But in the bone, there's less water molecules. So that the effective conductivity diminishes in the bone. So another comparison is grounding pads. Like I said, grounding pads are present in RFA to reduce the risk of burns. Whereas in microwave, there's no risk of burns because we're not giving electrical current. So there's no grounding pads required. Again, like I said before, the heat sink effect. The heat sink effect plays a major role in the dissipation of the heat from the target area by the blood vessels in the nearby region, which is more effective in RFA. But in microwave ablation, heat sink effect is attenuated. Unpredictable ablation zones, more predictable ablation zones when it comes to microwave ablation. Less of an ablation zone, like for instance, due to heat sink effect, the ablation zones are less in volume, and it also there's no gradual, like I showed you before in the graph, there's no gradual increase in the temperature along with the time. So the ablation zones are less in RFA and larger in microwave ablation. Because of this, there might be required multiple ablation sittings where patient have to come for many repeated ablation sittings, whereas in microwave is more effective, so a single ablation sitting is required. Procedural duration is longer when it comes to RFA. Procedural duration is shorter with larger coagulation volumes. Cost effectiveness is better in RFA and it's expensive in microwave ablation. Challenging in patients with pacemaker and surgical clips. Why? Because we're giving electrical current. And here it is not a problem. Microwave, no pacemaker and surgical clips do not pose a problem. So these are some of the comparisons when you compare both RFA and microwave ablation. Whereas significant to see here is the heat sink effect and also the ablation zones, the larger ablation zones for the microwave, and also the main properties here are the tissue properties for both RFA and microwave ablation. Both the electrical conductivity and thermal conductivity tissue properties vary for RFA, and in comparison, the microwave ablation has relative permittivity and effective conductivity. Let us now talk about some of the complications for both RFA and microwave ablation. It's quite infrequent, approximately 2 to 3%, but some of the complications would be hemorrhage, infection and abscess, visceral organ injury, liver failure, and mostly pneumothorax in lungs. The next topic I would like to shed some light about is the endometrial ablation. So endometrial ablation is basically it's safe and effective, minimally invasive surgical procedure that has become a well-established alternative to medical treatment or hysterectomy to treat abnormal uterine bleeding in select cases. So basically it's to treat AUB, abnormal uterine bleeding, in select cases. Endometrial ablation is very effective. So those patients that cannot have hysterectomy done, or those patients who have this AUB, that is abnormal uterine bleeding, this is an effective, minimally invasive and safe procedure. Only one drawback I would say is that it causes complete sterility. So that is maybe the only drawback I can see so far. So what are the indications and contraindications when it comes to endometrial ablation? First off, like I said before, abnormal uterine bleeding of benign origin may be considered as a primary intervention in circumstances such as intolerance to or failure of medical therapy or patient preference. May be considered for patients who refuse or are poor surgical candidates for hysterectomy. The absolute contraindications would be pregnancy, desire to preserve fertility, known or suspected endometrial hyperplasia or cancer, cervical cancer, active pelvic infection, and the specific contraindications related to non-resectoscopic techniques. So what is this non-resectoscopic techniques? Simple. It is the placement, it is actually what do you call it? It is an endometrial ablation using a technique of placement of the catheter right at the uterine cavity to ablate the lining of the uterine cavity. So this is what is called as a non-resectoscopic technique. So these are absolute contraindications. So now we'll talk about some of the investigations prior to endometrial ablation. So first is the pregnancy test. Then next you have the Papino-Colau test within 2 years. Cervical cultures if clinically appropriate. Endometrial sampling and assessment of uterine cavity for Mullerian anomalies. Or intracavitary pathologies using transvaginal ultrasound 1, contrast infusion sonography 2, or diagnostic hysteroscopy. So my next topic is hypothermic ablation. So as it says hypothermic ablation, underneath that we have cryoablation. Now cryoablation is also called cryotherapy or cryosurgery. It's a form of treatment that uses extreme cold to freeze and destroy cells, including tumors. Cryoablation is a method of destroying tissue by freezing, that is extreme cold is used to destroy tissue. Most often cryoablation is performed percutaneously. Cryoablation is performed using hollow needles, that is the cryoprobes, through which cooled thermally conductive fluids are circulated. Like let's take for instance here, this is the cryoprobe where it's a vacuum on either side and it's hollow in the center, through which argon gas, that is a coolant, is supplied inside. So as the coolant goes inside, what it does is it reduces the It's a very simple procedure where what it does is it reduces the temperature of the surrounding tissue gradually. As it reduces the temperature, it forms an ice ball around. And this ice ball around the tissue, this is what that causes the direct and indirect cell damage. Now, cryoablation, that is, you can say here, cryoprobes are used here. So cryoprobes are positioned adjacent to the target in such a way that the freezing process will destroy the diseased tissue. Once the probes are in place, the attached cryogenic freezing unit removes heat from the cools, that is the tips of the probe, and by the extension from the surrounding tissue. So what it basically does is the coolant is supplied inside and it removes the heat from the tip, and as it's removing the heat from the tip, the surrounding tissue also, it removes the heat and it forms an ice crystal which encompasses the target lesion and causes cell death. So temperatures of at least -20 to -40 degrees are required to cause sufficient cellular death. Cold temperatures emitted from the probe cause both intra and extracellular ice crystal formations. As you can see over here, both intracellular and extracellular ice crystal formations causes direct destruction of cellular membranes, resulting in direct cell death. Ablation occurs in tissue that has been frozen by at least 3 mechanisms. One is formation of ice crystals within the cell, as you can see, thereby disrupting the membranes and interrupting cellular metabolism among other processes. Second is coagulation of blood, thereby interrupting blood flow to the tissue, in turn causing ischemia and cell death. And the third process is induction of apoptosis, the so-called programmed cell death cascades. Then what is the outcome? The outcome of cryoablation is it causes cellular damage, death, necrosis of tissue by direct mechanism, which cause cold-induced injury to the cells. But there is also an indirect mechanism which causes changes to the cellular microenvironment and impair the tissue viability. Let's take, for instance, in this picture here, the light blue signifies the tumor cells, the dark blue signifies the area where the ice crystals are forming, and there's the applicator tip in black. So the region where the ice crystals are forming, that's called the direct injury. So direct injury, ice crystals are formed, it causes apoptosis. The indirect injury is caused by the microenvironment and the tissue viability, impairment of the tissue viability around the tissue. So how is this caused? It is caused by vascular injury, it's caused by vasoconstriction, platelet aggregation, microthrombosis, and ischemia. So all these factors form the indirect mechanism. So all this leads to reversible injury, which leads to apoptosis. Now the 4 major factors that affect both the direct as well as the indirect mechanisms is the cooling rate, the rate at which how fast the ice crystals are formed, the target temperature, the temperature which is at which the tip is maintained at, the time it takes to attain that target temperature, and the rate at which the ice crystals dissipate. All these, the thawing rate, all these are factors, these 4 factors determine the direct and indirect mechanisms for the destruction, or for, you can say, apoptosis of the cell. Let's now see some of the applications for cryoablation. To ablate solid tumors of the liver, lung, breast, kidney, and prostate. To treat low-flow vascular malformations such as venous malformation and fibroadipose vascular anomalies. It has also been proven that it is an effective treatment for the disorders, both as a primary treatment as well as after sclerotherapy. I want to highlight here the effectiveness of cryoablation by showing you a follow-up study involving a patient with complaints of liver lesions in the right lobe of the liver, as well as multiple nodules in the liver. So previous CT was done previous to the, before the cryoablation, which showed all these the right lobe lesion. And after the cryoablation, you can see as the follow-up study started from the first year to the second year, third year, fourth year, and the fifth year, how far the lesion diminished in size and how effective the cryoablation was in this instance. I would like to show you some case studies right now, which will show the effectiveness of both microwave as well as RFA when it comes to liver lesions and lung lesions and tumors, etc. First case study is for a patient that underwent microwave ablation for hepatocellular carcinoma. It's actually a 74-year-old male, clinical history of hepatocellular carcinoma in the left lobe, post-stage status. The procedure was under strict aseptic precautions and general anesthesia. 2 overlapping ablations of HCC was done using 100 watts for 10 to 6 minutes respectively. Post-procedure CT revealed adequate ablation. No procedural complications were seen. So as you can see, the pre-procedure, then the needle approach, the post-procedure after the ablation, and the follow-up. No complications were seen. The patient was advised to do triphasic CT scan after 4 weeks. Yes, this is another case of microwave ablation where a PET CT was done initially before the ablation. 70-year-old female, known case of CA breast, mastectomy done and stereotactic radiotherapy was done. Complaints of abdominal pain and backache. Bone scan is inconclusive. PET scan reveals metastatic liver lesions and biopsy was done, and then the ablation was done. So pre-procedural shows the affected area, then the post-procedure after the ablation, and then the follow-up study that showed that the ablated side had decreased, that is, the lesion had decreased in size. This is a case where radiofrequency ablation was done for a patient, a 45-year-old male, which complains of chest pain and breathlessness. As you can see there on the right hand upper quadrant, there is a lung lesion with rib involvement. Then, so that shows in the pre-procedural scan. Then the needle approach for the RFA was done. Then the post-procedural CT was done, which shows how well it was ablated. Then the follow-up CT at the end showed, after a year or so, showed how well the lesion had diminished in size. This is a case where the patient underwent a combinational therapy which involves both TACE, transarterial chemoembolization, as well as RF ablation, and the follow-up studies show how well the tumor lesion has diminished in size. I would like to summarize by stressing on few major topics that we have gone through in the last session. First would be thermal injury, the presence of the pads that help complete the circuit and reduce the risk of burns for the patient. The pad also acts as a dispersive pad that absorbs the thermal energy. Heat sink effect plays a major role in radiofrequency ablation, whereas it is attenuated in microwave ablation. Tissue properties vary for both microwave as well as for radiofrequency ablation. The tissue properties are electrical conductivity and thermal conductivity for radiofrequency ablation, and for microwave ablation the tissue properties are relative permittivity and effective conductivity. Heating temperatures, there are different temperatures for both RFA and microwave, and cryoablation uses very low temperatures. Electrodes, there are 3 different types of electrodes we went through: monopolar, bipolar, and multipolar electrodes. The introduction of saline infusion pumps, and their use, and then the different attributes for a proper microwave antenna. Then the various ablation zones we have stressed upon, when as in microwave ablation, as the power increases over the time, the different ablation zones. The various complications are almost the same for both RFA and microwave. And the clinical outcomes, how effective is RFA, how effective is microwave, how effective is cryoablation, and endometrial ablation is safe and less invasive. Let me conclude by saying loco-regional palliative treatments such as RFA, microwave ablation, cryoablation, endometrial ablation, HIFU constitute the backbone of interventional treatment of unresectable tumors. The two methods, that is RFA and microwave, they differ in mechanisms of action, having microwave more advantageous profile in terms of ablation volume, procedural time, and simultaneous treatment of multiple lesions. We have shown here that cryoablation is effective and more advantageous too. From an imaging technologist point of view, what we must possess is adequate clinical knowledge, conceptual and technical skills, should monitor vitals and stay alert always. These are some of my references from where I have taken most of my information from. Thank you to one and all present here, and hope you all are well.